May I now request Dr. Pradeep and Dr. Karthik Marutachalam to take over as the chairpersons and begin the proceedings for the debate between Dr. V Rao and Dr. Manu Nayar. Dr. Pradeep Jain.
Yeah. Can you hear me?
Yeah.
Yeah. Good evening, everybody. Now, we all know that the management of infected pancreatic necrosis is quite a controversial topic, and there's so many competing treatment modalities. Like if you could talk about surgery, interventional radiology, and endoscopy. There's a lot of controversy. One modality tries to score over the other, and there's no fixed algorithm or there's no fixed treatment management program to manage the infected pancreatic necrosis. So we have a debate, constant debate on this. So for clearing the aspects of management, we have two speakers, Dr. Manu and Dr. V Rao from Hyderabad, Dr. Manu from UK, who will be speaking about the endoscopic management and the surgical management of infected pancreatic necrosis. So invite first Dr. Manu to speak about the endoscopic management of infected pancreatic necrosis. Dr. Manu, please. Dr. Manu.
Hello, can you hear me?
Yeah, yep. You can hear you.
Okay, I'm just going to open my presentation. Can you see my presentation now?
Yes, we can.
Right, thank you. I'll start my video. Can you see me now?
Yeah, you can.
Okay. Good evening, and thank you very much for this very kind invitation to Dr. Goel, Dr. Jain, and Karthik, who we know from Newcastle. I think I'm one of the physicians who's going to be talking in a surgical conference, and I'm hoping in the next 10 to 15 minutes I'll convince you in this debate between endoscopic and surgical necrosectomy that endoscopic necrosectomy is the way forward. So necrotizing pancreatitis is seen in sort of 10 to 20% patients who present with pancreatitis, of which a third of patients actually require intervention. But the most important thing, the mortality in these group of patients is quite high. Now, treatment options for infected or symptomatic patients remain open necrosectomy, percutaneous necrosectomy, and endoscopic necrosectomy. By and large, if you look at the algorithm that is followed in our unit, in the Western world, and around the world, is a choice between invasive and minimally invasive techniques. The invasive technique, which is an age-old technique of open surgical debridement, is still being used in certain circumstances. But I think time has moved on. We are using more and more of minimally invasive techniques, which include surgical transgastric approach, retroperitoneal, and endoscopic. In the retroperitoneal approach, the Dutch came up with the idea of the video-assisted retroperitoneal debridement, but we've always been using percutaneous drains and debridement for the treatment of necrosis. However, direct endoscopic necrosectomy is something that I will be focusing on in my talk. So what is the evidence to choose between these three modalities? So this is the first, one of the first publications by the Dutch pancreatitis group comparing minimally invasive and endoscopic versus open necrosectomy in nearly 2,000 patients, to which patients from Newcastle also contributed to the study. And in this patient, majority of the patients underwent open necrosectomy, but around 813 patients underwent minimally invasive approach, including endoscopic necrosectomy. And the group concluded that, reviewing the results, in high-risk patients with necrotizing pancreatitis, minimally invasive surgical and endoscopic necrosectomy was associated with reduced death rates compared to open necrosectomy. And this has been confirmed by a recent publication where they looked at they compared a cohort of open necrosectomy patients with the minimally invasive approach. And in this, they not only noticed that the one-year mortality was significantly less with the minimally invasive techniques, but organ failure was also less compared to open procedures. But I just want you to pay attention to this table. The number of patients who had endoscopic necrosectomy was probably the commonest among all the techniques that they used. And again, this group also concluded that multidisciplinary, so that is the key here, multidisciplinary minimally invasive step-up approach to necrotizing pancreatitis resulted in 5-fold decrease in mortality compared with open necrosectomy and improved patient outcomes. So these two very strong pieces of data really moved open necrosectomy out of the algorithm for management of necrosis. So then it comes, which one should we be choosing, endoscopic or surgical step-up? So I'm sure many people in the audience know about this randomized trial, again from the Dutch pancreatitis group, comparing randomizing 98 patients to endoscopic versus surgical step-up approach. So the primary endpoint in both the endoscopic and the surgical group were no different. So there was no statistical difference between the two, with a p-value of 0.8. In addition, the mortality did not differ between the two groups, and major complications did not differ between the two groups. So we had now two techniques, two minimally invasive techniques that are being compared, and there really isn't much of a difference between the two approaches. So they concluded that the endoscopic step-up approach was not superior to the surgical step-up approach in reducing major complications or death, but the rate of pancreatic fistulas and hospital stay was much longer in the ones who went ahead with the surgical step-up approach. And one of the seminal things that they mentioned in the paper was the outcome of this trial will probably result in a shift to endoscopic step-up approach as the preferred treatment. And this has been sort of confirmed and endorsed by many of the international guidelines. So there's one from the European Society of GI Endoscopy, which says EOS-guided access should be the preferred conventional transmural drainage. And then there is the National Institutes of Clinical Excellence guidelines, which was released in 2018, which I was actively involved with, which said that offer people with acute pancreatitis an endoscopic approach for management of infected or suspected infected pancreatic necrosis when anatomically feasible. Offer a percutaneous approach when an endoscopy approach is not anatomically feasible. And that is, again, comes back to how do you decide, how do you allocate the patient? So we have actually been doing endoscopic necrosectomy since 2002. So it's a long time, it's nearly 20 years we've been focusing on this particular procedure. But it is not us as endoscopists trying to prove that endoscopic necrosectomy is the right thing to do. We have a remote care pancreatitis model where all patients with severe acute pancreatitis in the northeast region of the UK is referred to our unit. And then we decide what is best for the patient. And again, in a recent publication, if you look at the table again, it shows that endoscopic approach, again, is the commonest approach we take. And if we have to combine it with percutaneous surgical, it is still the endoscopic approach rather than the other way around, where we try with the percutaneous or open necrosectomy and then move on to endoscopic. I would also like to sort of mention at this point that in the last 3 years, we've only done one open surgical debridement of pancreatic necrosis. So why am I debating about endoscopic necrosectomy? I think a lot has changed in the last 10 to 20 years, because of which we should be paying attention to this particular technique. Some of you in the audience who are involved with the management of necrotizing pancreatitis would remember the old days where we used to look at things endoscopically, make a hole through the stomach into the cavity, and try and take out necrotic material, similar to the picture on the right. This was effective, but it was blind. We didn't know where we were putting these graspers in and what we were grabbing. We could be grabbing blood vessels, we could be grabbing necrotic tissue, or even the wall of the tissue. So when we first started this in 2002, we published our series in endoscopy. But then times have moved on. We've now got these fully covered metal stents, and there are different varieties. The first one that all of my colleagues in India would be aware of is the Tewung Nagi stent, which essentially was a biflange stent. So it held the pancreatic cavity wall, but also held the stomach wall, but it wasn't lumen opposing, it just held it together. But what it gave us is the ability, if you look at the picture on the left, is to actually enter the cavity. So it's direct endoscopic necrosectomy to take the necrotic material out. And once you've cleaned it, this is what it appears like. It is a nice clean cavity. Once you've done the job, then you take the stent out.
Dr. Manu, sorry to interrupt you. That we're running short of time. Actually, you'll have to hurry up because after this, V Rao has to speak, and after that there will be rebuttal. So
okay,
kindly, can you hurry it up?
Yeah, sure. So I think I mentioned about the lumen opposing stent. So lumen opposing stent just helped us approach the cavity and take the necrotic material out, which again we published in 2017. So what are the practical advantages? Yes, it's minimally invasive and there's no risk of cutaneous fistula, but the new devices enable us to do the procedure in a shorter period of time. It is versatile, so you can do it in the endoscopy unit, you can do it in ICU, and that prevents moving the patient into theatre, and there could be potential cost savings there. So to conclude, there is increasing evidence to suggest that endoscopic drainage followed by direct necrosectomy is the procedure of choice for the treatment of pancreatic necrosis. It is associated with low mortality, it is minimally invasive, and could result in potential cost savings, including reduced length of stay and number of repeat procedures. But I would like to emphasize, and the lack of time has made it difficult for me to do that, but it is best managed in a network to enable patients to get the best possible treatment, because more and more endoscopic intervention is required in these patients. Thank you very much for listening.
Thank you, Manu. Can we call upon Dr. V Rao to speak next, please? Dr. V Rao does not need any introduction. He's an eminent surgeon and director of the Asian Institute of Gastroenterology, Dr. V Rao.
My screen is visible?
Yes, sir.
My screen visible? Okay.
Yeah, it's okay.
Yeah, thank you. Thank you, Manu, for that fantastic presentation. This is my disclaimer slide. Actually, nothing against anybody, no group, no individual, please. Now, in fact, the surgery has been the gold standard, and all the management concepts have evolved from surgery, and this is what we do: delay, drain, debride, deviate. And if you deviate from this, actually the mortality is very high. The Panther trial, which came in 2010, seems to have changed the entire concept, and this is what created attention among the endoscopists, and they started practicing endoscopy very vigorously. And Todd Barron created WAN, which is an endoscopic definition, which means there is fluid, it is pseudocyst, there is debris, it is WAN. So basically, there is a difference between debris and WAN. WAN constitutes both of them. Surgically, what we believe is this is debris and this is necrosum. There are two different aspects when we're talking about these two things. Now, in 2020, endoscopic interventions are endoscopic ultrasound based, and EOS is highly sensitive to detect debris, and the conversion rate is very high. So what all CT pseudocysts that surgeons have been draining have become endosono WANs. And most of the WANs in endotherapy literature are in fact CT pseudocysts. Now, if you ask me a simple question like this, which among the following is WAN? I mean, the endoscopists obviously get baffled like this, because for them, only we are talking about WANs which are in close approximation to the stomach and duodenum. You don't talk about these paracolic extensions, you don't talk about these mesenteric extensions, or you don't talk about the mediastinal extensions. Now, these are called as extended walled of pancreatic necrosis, which obviously cannot be dealt with endoscopically. And we have umpteen number of these stents, fully covered lumen opposing stents. Actually, as Nayar has told you, they have become the gold standard for the management of these things, but these are all industry supported this thing. And you can see this is a beautiful meta-analysis which has come. It's shown that there is no difference between using a metallic stent or a plastic stent. I'll tell you why. This is a beautiful study which is published from our own study to see where they have done a step-up approach to treat walled off pancreatic necrosis. And you can see this, of the 225 patients of walled off necrosis which they underwent, 75% of these patients did not require any debridement. Please, just put in a stent, the debris or the fluid came out and the patients did very well. And of the 25% of the patients who underwent, 10% underwent declogging, some patients underwent putting in a nasocystic drain, and only less than 10% of the people required an actual debridement, please. So whether you put a plastic stent or a metallic stent, it does not make a difference, and only less than 10% required debridement, because majority of them have just debris and not much of necrosum. And this is the beautiful study which shows almost 90% of them can be tackled just by putting in a stent, whatever stent you want to put in, and then the patients do very well. Now, there's a myth that the gastric juice aids in clearance of necrosis. Absolutely not. And because we have a lot of limitations on the endoscopy side as to how to extract this, we'll not be able to do a complete necrosectomy. And this is a beautiful thing that has come, a worldwide multi-institutional endocrinologist consensus as to how to treat. As in today, there is no consensus. Actually, this is a beautiful paper which shows there is lack of consensus about how endoscopic ultrasound-guided necrosectomy has to be done, and we still have to evolve ways and modalities to treat this. Surgically, we have three modalities: open, laparoscopy, and retroperitoneoscopy. Laparoscopy is transgastric, retrogastric, retrocolic, retroperitoneoscopic. All potential areas can be drained. Complete removal of necrosis is possible. It is augmented by the result of using some sort of a hand port. And if you see, the overall results are not very, as said, actually the mortality is not very high, and the success rates are very, very high. This is a beautiful experience that is quoted from our own country, which shows that laparoscopic interventions are very good, and the pancreatic fistula rates are very, very low as compared to what is quoted in the literature. But retroperitoneoscopy is the other modality to use. Actually, we either use an Optiview trocar or a single port trocar. We use our TEM port to do this. Actually, it's a direct visualization. We have rigid instruments to do the complete necrosectomy, and you can see you can avoid all these major vessels that are here, the retroperitoneum, and you can irrigate the entire cavity. And once you're done with the procedure, we can put these drains and come out. And these patients do extremely well. You can see the patient here that doesn't get into the peritoneal cavity. These patients do extremely well, and we have a lot of literature to show that the overall mortality, morbidity is very less with these procedures. Now, with this, is open necrosectomy still obsolete? Actually, I mean, I don't concur with Dr. Manu saying that open necrosectomy is not done nowadays. We have this various technique, but the close continuous lavage is the one which is mostly do additional procedures like or feeding jejunectomy or an ileostomy or dissections can be done. Just to show you, this is the necrosum, this is the debris. After this, we do put in this vein to do a post-continuous lavage. We also treat patients for post-endotherapy complications for bleeding, perforation, infection, stent migration. These are the stents put in. Unfortunately, whichever one goes to the endoscopist, they put in the stent, actually, irrespective of the one. This is one such patient who had the one placed into the cavity which is anterior to the stomach. You can see there are two pigtails put into this, and obviously leaving this ward of necrosis here. This patient underwent an open necrosectomy. Again, a Nagy stent which is put in. Again, patient has to be salvaged. They take the stent out and do the debridement. And then this is one such patient who had a colonic perforation. Endoscopic drainage was done, but he had a huge colonic perforation. And obviously, this patient requires a resection and an ileostomy and a drainage. And this is another patient, massive bleed following endotherapy. You can see this. We opened the patient, massive bleed that is occurring from the thing. Once you remove the clot, you can see that there's a huge rent in the splenic vein, which is torrentially bleeding here. These obviously cannot be controlled with any sort of endoscopic treatment. Even in surgery, it becomes very, very difficult. You can see this gush of fluid, blood that is coming out from the splenic vein that is controlled by open surgery and ligating these things. And if you see the overall outcomes of different open techniques, the mortality, morbidity is not very high. It's quoted in the literature. The mortality is less than 10%, and the complications rates are also very low in this. Now, open necrosectomy, this is a beautiful paper which shows that the mortality rate of necrosectomy is about 11%, and more than 50 mortality if multiple risk factors are present, and if there's no mortality, if there are no risk factors. And if the patient undergoes prior interventional radiology or an endoscopic procedure, obviously the results are bad. Now, this is a beautiful review from Gangaram Hospital, which shows that huge number of patients still undergoing open necrosectomy in these patients, in spite of having all possible technologies in this tertiary care center. Now, this is the paper that I would like you to see, wherein all the endoscopists, surgeons, interventional radiologists are involved. And this is the data which shows 51 hospitals across 8 countries, 1980 patients, and you can see that more than 1,000 patients undergo open necrosectomy, minimally invasive surgery in 467, and endoscopy in about 346 patients. And you can see these are several challenges even within our country, even in the 3-tier cities. These open necrosectomies are done with absolutely minimal morbidity and mortality. Now, whatever trials have been quoted, there's bias selection. There are selective wounds in endotherapy sessions, wounds which are absolutely localized to the stomach or to the duodenum with less than 30% debris. And comparison with, they're compared with all wounds undergoing open surgery, not minimally invasive procedure. and there are a lot of trials which show there is no significant difference between these two. Now, this is the one which shows endoscopic versus surgical treatment. We don't have adequate evidence. We still need good trials to show comparative patients to show which is superior to what. Open transgastric debridement has got similar morbidity to other minimally invasive techniques. Beautiful paper, and this paper shows that we have various procedures that can be done. Surgical transgastric necrosectomy is a good single-stage procedure, and the outcomes are absolutely very good. Now, this is the paper that compares head-to-head, less than 30% debris, endoscopy, and laparoscopy, and you can see this. The post-operative complications are comparable for higher post-procedure infection in endoscopy group. Otherwise, the results are similar. This is the comparison that we want. Less than 30%, yes, you can hand to good opposition to the stomach and duodenum. Both of them are equal. And we have, initially, all our patients used to go for endoscopic drainage. Subsequently, we decided that there's a lot of issues concerning this. Now we have a pancreas board which sits in the endoscopists, the surgeons, the interventional radiologists. And you can see that the number of surgical procedures have dramatically increased after we started having this tumor board. And obviously, if you see our own data from this, primary surgery, the mortality is very, very less. But once the patient comes post PCD or an endoscopic drainage, the mortality obviously increases. So if you see the...
sorry, Dr. Rao, I'll interrupt you. Yeah, I think you will have to also cut it short.
Yeah. Now, it is in approximation to the stomach, less than 30% endoscopy and straight surgery, more than 30% open or laparoscopy. If it is beyond stomach and duodenum, more than 30% debris, IR or open laparoscopy. More than 30% debris, unstable patient, IR or open surgery. Stable patient, radiology followed by open surgery, or if patient can be taken up for surgery directly. And if it's complicated because of enteric communications or bleed, any of these things, these patients obviously require surgery. So who can do this procedure? Actually, this becomes part and parcel of general surgical training program. Even a general surgery candidate can do this, but endoscopic ultrasound, obviously, only super specialists can do this procedure. Now, this is a beautiful paper which comes from Shyam Govardhan, which shows that absolutely lesions, ones which are good localized to the stomach and duodenum are the ones which can be tackled endoscopically. All other things require some sort of surgical intervention. So to correct this, is the nomenclature correct? Is endoscopy biased? Site, only stomach and duodenum can be tackled. All can be tackled surgically. Debris, less than 30%, 100% debris can be tackled. Complicated ones cannot be tackled endoscopically. Complications are more endoscopically. Additional procedures can be done surgically, not endoscopically. Cost, expensive. Can everybody do it? No, on endoscopy side. What is the strength of impact? Low, and it is industry driven, whereas here it is patient driven. So basically, we need to have consensus, guidelines, practice, and we have to evolve board standard before we can switch over from conventional this thing. Otherwise, it will become something like this. What has happened for the presidential election? Even before the election, this lady was declared the president, and subsequently results came in subsequently. So if you still feel that you're still not convinced, this is the thing that I keep showing to the in my all my debates with the endoscopists. This is the question that is posed. What is George W. Bush's first name? 4 options given. This lady takes a 50-50 chance, left with Edmund and George. Then she takes a call from phone a friend. The audience says it is Edmund, but she goes with George. So this is what happens irrespective of whatever evidence that we have. A lot of evidence to show that minimally invasive surgical procedures, laparoscopic procedures are good. Endoscopic procedures are evolving. I'm not saying endoscopy is very good for less than 30%, good approximation to the stomach and good procedure. But for all other procedures, I think we have to have a multi-model.
Dr. Rao, we have enough time in the rebuttal. Please, can you cut it short?
Yeah.
We're running short of time.
Thank you. Thank you so much.
Thank you so much. It's a very powerful presentation by both the speakers. So there's a time of rebuttal now. We have 2 minutes for each. So can we, I request Dr. Manu to have some viewpoints against Dr. G. V. Rao.
No, so I think, thank you, Dr. Rao. That was an excellent presentation, and you put your case forward for surgical intervention. But I would like to point out a few flaws in some of the studies that you mentioned. They were all very old studies. They're now more than 10 years old. Secondly, your algorithm of less than 30%, How do you know? How do you calculate less than 30%? Because that is a challenge both for the radiologist and definitely for the endosonographer. And I think I take your point about extended necrosis, which is in the paracolic gutters and the mediastinum, etc. There, an endoscope can't get there. But if you think about pancreatic necrosis, 70 to 80% are confined to the region around the pancreas. And if you have an option, and if you've got a multidisciplinary team, which involves the surgeon, the endoscopist, and the interventional radiologist, then I certainly feel with the emerging evidence over the last 5 to 10 years, I would certainly take the endoscopic approach rather than rush in with the surgical approach. But just like you may have seen less complications with surgical intervention, we have actually seen a lot more complications with surgical intervention. And I'm saying this because I work in a center, and Karthik knows about this, where the surgeons are very, very heavily involved in the management of pancreatic necrosis. So yes, surgical necrosectomy has a role, but I would still go for endoscopic intervention as the treatment of choice. Thank you, Dr. Jain.
Manu, can I have just a few words? Is it possible that you have sort of improved your technique for a period of time, in the sense that because you've been doing so many of these procedures over such a long period of time, that you have developed the expertise to do them, whereas in a low volume center this may not be possible. So I think that is what Dr. Rao is trying to emphasize, I think, because being a surgeon, some part of me wants to agree with him, but I have seen your work myself, so I have to go with the endoscopic side as well. So do you think that you improved over the years?
That's a very good question, Karthik. And being a surgeon, with every sort of advanced intervention, including advanced surgery, there is a learning curve. So when people started doing laparoscopic surgery, there were a lot of surgeons said, no, laparoscopic surgery is not going to replace open. And now it's become the norm. And the same applies for our endoscopic approach. You're absolutely correct. We work very closely with our surgical colleagues. So just like Dr. Rao put at the tumor board, we have a pancreatitis meeting every Wednesday morning for an hour, where we decide what is the best option. Some of the patients might require endoscopic and percutaneous. Some may say, well, we'll only go for percutaneous because we're not going to get rid of this endoscopically. So that technique, our technique has certainly improved because we've been doing this for nearly 20 years. And we've been not just doing the procedure, but analyzing the data and publishing it.
Dr. Rao, I have a question for you. Would you not agree that a step-up approach or a combination of endoscopic and surgical techniques is the way forward, rather than just emphasizing on...
No, Karthik, what I'm saying is, if the debris is limited, endoscopy is best. I don't deny it. I'm not denying that fact at all, actually. I'm not denying that fact at all. But if you see most of the thing, actually, what happens is basically, I think what the endoscopic ultrasound has changed the entire management. See, debris 30% is calculated by the endoscopist. Actually, whatever the literature that is published, actually, they said 30% debris calculated based on endoscopic ultrasound or an MRI picture. That is what is documented. So basically, what happens is, I'm not saying, this procedure, endoscopy is good. My unit does huge number, but I've shown the step-up data which shows 70% you put the stent, they do well. You don't do any debridement. So, but when it comes to surgery, you understand what I'm saying? Actually, when it comes to surgery, it's a totally different thing that you're talking about.
Are you saying that it's a difference in assessment by the endoscopist and the surgeon?
Yes, absolutely. You're taking all those cases which are absolutely good ones and good approximation to the stomach and duodenum. And we have data, if you compare those things, actually what the AIMS group has compared and showed it to you, and if you have that's a head-to-head comparison. And the results are absolutely the same in both the things, actually.
Manu, one of the problems is the use of stents. It's very expensive, and that's true. In India, it's quite hard to use a lot of stents. So, what would you say, to us in that aspect?
That's a good point. That's a very good point you raised, Karthik, because these stents are costly, and as Dr. Rao mentioned, it's very much industry driven. So I think something has to happen whereby industry also has to try and understand you can't sell stents which are costing 1.5–2 lakh rupees because it's just ridiculous. It cannot be used by anybody and everybody. So I think that the cost has to come down. But what I was trying to demonstrate is the direct endoscopic necrosectomy. And I would like to pick on Dr. Rao's point about the necrosis. In Newcastle, some of the cases we do, have got more than 50% necrosis. And these are extremely complex cases. I did a case last week where I could not see any fluid when I put the stent in. It was only necrosis. And this guy has now had five sessions of direct endoscopic necrosectomy. He's out of ITU, in the ward. He also had a percutaneous drain because there was something tracking down into the right iliac fossa. So he needed a combination, but majority was done with endoscopic intervention. But you need a team. You really need a team around you. Absolutely. And the cost of the stents have to come down because they are just too expensive.
I fully will agree with Manu. See, this happens in only select few centers across the world. I mean, the sort of necrosectomy that you can do it, actually, maybe it can be done in select few centers. It cannot be done in general.
Sure, agreed.
Okay.
I agree with you, Dr. Rao. Yeah.
Okay, thank you both. Both of them are excellent presentations. So we'll watch the space.
I believe that it's very, very unfair to compare both this technology head to head. I think they have a role. The different type of patients have different kind of requirement. So I think they can be considered both as a complementary rather than a competitor. So by this, I end this session or debate. And thank you so much for both the speakers. And
thank you.
Thank you very much for the invitation. Bye-bye.
Bye, Manu.
Thank you all very, very much. Thank you, Dr. G V Rao and Dr. Manu Nayar and Dr. Pradeep and Dr. Karthik. That was a very, very interesting debate. And I think, the digital...
Dr. Bhojwani, do we have a recording of this? I think this is a very...
I
have a recording of all this?
Yeah, it's getting recorded.
Okay. That's good, because one of the best debates I ever heard. Thank you so much, everybody.
Well, I hope I haven't upset Dr. Rao.
No, not at all.
I hope I'm not upset you, actually. I hope I'm not upset any of the endoscopists, please.
Okay. Well, enjoy your social evening.
Thank you.
Thank you.
And the good part is that we are there absolutely well in time, and there are 4 more minutes to go before this also joins the plenary session at 6:15. And I think it was a very exciting and a very interesting day all through, starting with the live workshop in the morning and all the interesting videos and didactic sessions all through. Thank you all very much for sparing your time and the entire effort that you've taken. And please join us for the plenary session just about 3 minutes from now.
Thank you.
Thank you, Dr.
Bye.
How are you, Karthik?
I'm fine. How are you?
Yeah,